Namaskar. Greetings from Indian Dental Association West Bengal State Branch. On the occasion of Oral Hygiene Day, that is on 1st August, in commemorating our Doyen of Periodontics, Dr. G.B. Shankwalkar, on his birthday, it has been observed as Oral Hygiene Day and National Oral Health Day. ডক্টর জিবি শাঙ্কওয়ালকারের জন্মদিন উপলক্ষে আমাদের এই ভারতবর্ষব্যাপী ন্যাশনাল ওরাল হাইজিন ডে মানে মুখের স্বাস্থ্য সচেতনতা দিবস পালন করা হয়। তো ইন দিস COVID-19 সিচুয়েশন it is very difficult to reach out people in physically and go for health camps, dental camps. সেই জন্য আমরা these days we are present virtually. We are coming to you via webinars and we are trying to reach out people towards the different ways of maintaining the oral hygiene, and we are trying to say you few things about the oral hygiene. So in this regard we have with us today Dr. H.S. Grover, Secretary of Indian Society of Periodontology. He will be giving you a message on oral hygiene. And following, we shall have Dr. Professor Nimfia Pandit. She will be delivering a lecture on modern advancements of oral hygiene techniques. So we hope this will be very much helpful to you. And IDEA West Bengal State Branch have been doing this oral hygiene day celebrations last few years, and they have been getting nice prizes, first prizes, second prizes. So we expect all of you to be there, এবং আমরা চাইবো আপনারা নিজেদের মুখের স্বাস্থ্য বজায় রাখবেন, সুন্দর করে রাখবেন, এবং এই COVID-19 সিচুয়েশনে যা যা করণীয়, what all things you have to do as per the government protocols, সেগুলো মেনটেন করবেন। থ্যাংক ইউ, ওয়েলকাম। নমস্কার।
Namaskar, friends. On the happy and pious occasion of Oral Hygiene Day, which we nationally celebrate on the 1st August every year, I greet you on behalf of Indian Society of Periodontology. To all my dentist friends, periodontist friends all over India, globe, and especially my brother and sister dentists practicing in West Bengal. A very happy Oral Hygiene Day to all of you. Friends, this day has a very significant role in our annual calendar because we celebrate 1st August or the Oral Hygiene Day in the sacred memory of Professor Dr. G.B. Shankwalkar, who was one of the pioneers in establishing oral care in the country. So 1st August, being his birthday, is celebrated all over with great enthusiasm, and we as a society try to pass on his message to the community at large. Friends, we all know that periodontics is the mainstay of all oral health related issues, and therefore a healthy periodontium always acts as a foundation for healthy teeth and gums. On this particular day, we try and spread the message of how to prevent the routine oral diseases, and we try to do so by using different platforms available to us. This year, because of COVID pandemic, we are refraining from holding community dental camps, but on a large scale, we are celebrating the Oral Hygiene Day on virtual and digital platforms, which I am sure our friends in West Bengal are also doing with lots of uh, guts and enthusiasm. You see, every year we are doing all these preventive programs throughout the year, but very significantly, 1st August remains a landmark for us. So this year we have a small theme of each one donate some. So this particular theme is that each of the dentists or periodontists or other specialty dentists to commemorate Oral Health Day should donate some oral hygiene aids such as toothbrushes, tooth, uh, toothpastes, other dental hygiene aids to all the needy in the community. The idea being that we must percolate the message of maintaining a good oral hygiene to all of them, and along with that, we give them some toothbrushes, toothpaste, etc., so that they can practice the same. Friends, donating the oral hygiene aids to the needy would really serve the purpose of philanthropy, which we dentists are always known as. I'm sure the team of dental experts, which is celebrating the Oral Hygiene Day in West Bengal, would do a lot of good work on this occasion. Therefore, in the end, on behalf of Indian Society of Periodontology, I once again greet you all on the Oral Hygiene Day. Stay safe, stay healthy, stay happy. Thank you very much. Jai Hind. Namaskar.
Hello everyone, I am Dr. Nithya Pandit. I am the President of the Indian Society of Periodontology, and I am Professor and Head in the Department of Periodontology in DAV Dental College, Yamunanagar. And today, actually on 1st August every year, we celebrate Oral Hygiene Day in memory of our great doyen of periodontology, that is Dr. G.V. Shankwalkar. It was his birth date, and every year we celebrated because he was one of the pioneers in India who started the specialty of periodontics in India. So today I'll be sharing some basic oral hygiene methods and what the advances are in the oral hygiene techniques over a period of time.
Topic of my presentation today is recent techniques of the oral hygiene maintenance. So it was long back in 1960s when Lowe actually established the fact that plaque is one of the most important etiological agents in the uh, periodontal diseases, and so it makes sense that we remove the plaque by toothbrushing, and that's the way that we can control this disease. And there are some facts before we go into how it should be controlled and what are the best methods of controlling it. We need to know the statistics. If we see most of the patients that come to us, they say that we do brushing every day, and we have been doing it since childhood, then still why am I having this periodontal disease? There are some facts which have been picked up in the most of the population in India, that it's right that they are doing uh, brushing every day, but the mechanical plaque control is not actually properly practiced by most of the individuals. And if we see some meta-analysis, it has been seen that some chlorhexidine agents, like the chemical plaque agents, they do exert some anti-plaque activity. And if we are thinking about the use of antibiotics, it has been suggested that it's an adjunct and not the main way of controlling plaque. So, and the systemic review also has also questions whether we should use antibiotics for the control of the plaque, and because the effects that we get, additional effects by the use of antibiotics, are very small. They are not very, there is not much difference between only mechanical and the addition of antibiotics in these. So, and another problem that is with antimicrobials is that we have been seeing a growing resistance with many of the antibiotics, and we are going to higher and higher antibiotics. And I read an article somewhere that we're almost scraping the bottom of antibiotics, the highest level of antibiotics. So with this background in our mind, it's very important for us to develop methods of proper plaque control without using any antibiotics. So the most important that we all of us know is that there is mechanical plaque control, which consists of toothbrush, interdental aids, and others. So we'll not be talking in details about this because we will be going to most of the advanced methods. The most important thing about the plaque control is that if we look at the definition of plaque control, it says that plaque should be removed from all the surfaces of all the teeth on a daily basis. So if it's a mouth where the teeth are properly aligned and we don't have any irregularities, or we don't have any processes in the teeth, then the most of the individuals can use toothbrush and floss, and they can have a good plaque control over this. But look at these different individuals where there is irregularities, there is a use of these bands, and there is crowding, there is excessive accumulation of plaque. And in these cases, it's very well understood that the gingival morphology or large tongue or the irregularity of teeth will impede the normal plaque control methods. The brushing, there are areas where the brush will not reach, or the patient is not able to clean all the surfaces of these teeth. So these are the problematic patients where we have to think. So every irregularity in the mouth, we add almost 1 minute. One irregularity, we add 1 month. One prosthesis, we add 1 minute. So if we take 2 minutes as the minimum time to have a plaque control, then we should think about adding 1 minute for every irregularity in the mouth. So if we, it's sort of like having an individualized periodontal assessment and individualized period plaque control methodology or plaque control instructions for that patient. So if we have, for example, processes, we add 1 minute, we ask the patient to brush not only for 2 minutes, we ask him to brush for 3 minutes. Then every other irregularity, we add 1 minute each. And accessibility is also impaired by the periodontal disease. So if we have increasing pocket depth, there will be plaque accumulation in that will cause more pocket depth, and that will reduce the efficiency of plaque removal. So if we are having removal of the accessible plaque, that will lead to gingival shrinkage, and it will be easier for the patient to master the basic technique of plaque control. So what should be the frequency and timing? Every time we say that we should clean twice, and we should have in the morning and evening brushing. But the problem is that most of the people are very busy in the morning, and to add that we should do sort of mindful brushing morning and evening, the people may not get time about that. So it has been seen with research that anyway, we are saying that every 24 or 48 hours the plaque should be disrupted. So why not have a method where the individuals can pick up the time of their choice, and they can brush any time in the day whenever they get time. So don't make it very demanding on the patient that he has to do it in the morning, evening. If he finds time during the after lunch or before breakfast or after breakfast, it's okay, because we need to remove the plaque every 24 hours. So it also depends how much cleaning the patient is able to do. It also depends upon the patient's degree of susceptibility. But for example, if the patient has more pocket depth, amount of plaque removal will be, of course, decreased. If he has less dexterity and motor skills, then also he may not be able to reach all the areas or the corners or nooks of the oral cavity. And if he, of course, he has some processes or any other filling in the oral cavity that makes cleaning difficult. So all these factors need to be taken into consideration before giving any plaque control instructions to the patient. So that is tailored type of plaque control instructions. So we should ultimately encourage all the patients to clean up to optimal level to his best of the ability, and gradually this can be modified. See, if a patient comes to you at the age of 40 years, he has already developed a kind of habit, and it's very difficult to break the habits. At that time, we should look at only the problematic areas and try to modify that only. If we try to thoroughly change all his method of brushing, he may not be able to take it. So it should be done in steps, and he should be encouraged to brush the way he's brushing, plus modify some areas where there are the problematic areas. So the more susceptible patient will need a number of techniques, and time commitment can be considerable. Often we can say that up to 15 minutes of patient's time on a daily basis if the patient is actually having advanced periodontal disease. There's a common misunderstanding that is held by many patients is that their cleaning is not it has to be exactly according to the technique. So if we can encourage them to clean at any time with whatever technique they are doing and modifying it slightly, then we can expect more adherence to whatever instructions we are giving. So there have been world and European workshops on periodontology, and they say that if we look at the design of a toothbrush, they say that they have conducted studies over many types of toothbrush designs, and they say that no one toothbrush is superior to any other, and the method is more important than the type of brush that we are using. And now that we are going to the advanced method, this was about the mechanical plaque control with the normal toothbrushes. Then over a period of time, when we saw that these brushes were not able to remove plaque effectively, then it led to the development of electrical toothbrushes. They have been introduced in the market about 50 years ago, and it was Broxodent by Benman and Wong who first gave the uh, importance of the electrical toothbrushes. And these electrical toothbrushes have the ability of oscillating in a oscillating motion and a rotatory motion, and both have the advantages. For example, oscillation will be more important in those patients where it's an orthodontic patient, and he needs to clean behind the braces and behind the wires. So a combination has also been developed. See, you are looking at the screen. There are so many types of power toothbrushes that are available in the market, and everyone has its own indications. The most important thing when you're choosing a power toothbrush is that the head should be small, because it's rotating at its own pace and at its own rate. So if we in the nooks and corners, it may not be able, if it has a big head, it may not be able to reach the nooks and corners of the oral guard. So the smaller the brush, that is better efficiency it has. Of course, there are special power toothbrushes for the orthodontic patients that should be used by them. There is another advancement in the toothbrushes where they are called as ionic toothbrushes. Ionic toothbrushes, as you know, that tooth has a negative charge, and the calcium salts which form the plaque and the calculus on the tooth surfaces that have a positive charge. If we had a brush that had a negative charge, that would attract the positive charge of the calcium and loosen the bond between the tooth and the plaque, and it would be easier for the patient to remove that. So ionic brushes were developed with this concept that the brush has a negative charge, and it will attract the positive charge, that is the adherence of the plaque with the tooth surface, loosen the bond, and it will be easily removed from the tooth surface. So there have been some research, and it has been seen that is of course better than the normal toothbrushes. Another advancement is the sonic toothbrushes. Here, the plaque is disrupted by the mechanical disruption, but it also has a generation of a dynamic fluid, which causes acoustic energy and leads to the disruption of the bond between the tooth and the plaque. There's a mild cavitation and streaming in the fluid surrounding the teeth, and the plaque is disrupted almost up to 4 millimeter beyond the physical reach of bristles. So it would be, we could understand by this that even in the interdental areas where we think that the bristles don't go deep into the interdental areas, this brush would be able to remove the plaque in those areas also. So apart from this, there are interdental cleaning aids have been developed over a period of time, particularly in patients where there is a recession in the interdental areas and there is loss of papilla. In those areas, there are more chances that there will be food and plaque accumulation in the interdental areas. So, and as we know that in the posterior areas, gall is the main area which is susceptible to the plaque accumulation and the disruption at the first instance by the plaque bacteria, and that is the area where we develop gingivitis and periodontitis. So it makes sense that we have tools to remove the plaque from the interdental areas. Plaque control in these areas have to be, again I was telling you that plaque is has to be disrupted mechanically. It cannot be just removed with a brush, with a power jet or by the jet of water. So the methods chosen should be properly taken up, and the instructions should be clear to the patients, because one of the most important abuses of the interdental cleaning aids is that the patient does not use it properly and there is more harm than benefit to the patient. If the patient is trying to put the interdental brush deep into the papilla, then the chances are that there will be loss of papilla and the development of anesthetic black triangles in the oral cavity. So floss is to be recommended for most of the patients, because that is where if there is no papilla loss, and if there is some amount of recession and papilla loss in the interdental areas, we can go for the tufted bristles, which are exceptionally useful in these areas. Such subgingival cleaning, if carried out regularly, it can have profound clinical effects. Now, apart from this, because some patients do not find it very easy to use the interdental brushes, we have recently there is the introduction of micro brushes, which have for the interdental cleaning. You must be knowing about these micro brushes, which are used in for the application of gels and resins and the restorative procedures. The same type of microbrushes have been introduced for disrupting plaque in the subgingival areas or in the interdental areas. With perseverance on the part of operator and the cooperation on the part of patient, most patients can master most of the techniques. So if we are comparing interdental brushes and dental floss, so what is preferred? Of course the indications are different, but if we given the choice, what is the preferred method? We know that interdental brushes are easier to use because it's very difficult for a patient to learn the technique of proper flossing, and brushing is simpler to use, it's less consuming, it's more efficacious than floss for interdental plaque removal, but it can lead to formation of black triangles if the interdental recession is not there. Another thing that is important from the professional point of view is how do we assess the plaque control. We can use disclosing solutions because plaque as such is not visible unless a large amount of plaque accumulates on the tooth surfaces. It's not visible to the patient. So if the patient doesn't feel that he is able to remove the plaque, he may not be motivated enough. For that motivation and for teaching better skills to the patient, we need to use the plaque disclosing tablets or solution that actually there is a two-tone solution which dyes the plaque, older plaque blue and the newer plaque pink, so we can make an assessment about how long the plaque has been there and how you can disrupt that plaque. They should be also used in those patients where we cannot control bleeding because of the plaque accumulation, so the patient can be shown exactly where the plaque is and how he has to remove it and how he can control the bleeding in those areas. A systematic review was carried out where we saw that the adults how much efficiency they had with the manual toothbrushes. It was seen that the adults with gingivitis, the quality of self-performed mechanical plaque removal is not efficient enough. So it was based on a study of 6 months that single oral hygiene instructions, if we give single oral hygiene instructions, it's not going to change what I was telling you, the lifelong habit. So it has to be a it has to be a continuous procedure. Every time the patient comes to you, you have to give the plaque control in a session, and you have to reinforce what you have taught. It's not that once you have given the instructions and the patient will learn it. It's very difficult for the patient to introduce new habits for the plaque control or brushing for his daily life. So you need to, every time he comes to you, you need to reinforce what he's saying, and you need to modify what he's not able to do. So this study actually, which was carried on many subjects, and it was like a systematic review for so many articles, and about 3,223 titles and 33 trials were used for this trial. So we need to understand that we are taking more time to give the instructions to the patient, and every time we are reinforcing it. That's very important. So another study which monitored on a regular basis how much they recognize the benefits of high oral hygiene, the incidence of caries and periodontal disease, as well as the tooth mortality in this subject sample was very small. And what we found out that caution must be exercised when comparisons are made with longitudinal study that present oral disease data from randomly studied subject samples, meaning thereby that if we see that heterogeneous studies are there, the data may not be taken as such. So if you are analyzing a number of studies for outcome or for the conclusions, we should be able to have homogeneous studies rather than the heterogeneous studies. So there was another systematic review which from 2,179 titles and abstracts and 132 full articles were screened. There was this is very important because there is something which is called as professional mechanical plaque reduction, and then oral hygiene instruction. It was shown that only providing the professional removal of plaque without giving oral hygiene instructions is useless. Only if you are giving only oral hygiene instructions, that may be more helpful. That this actually reinforces the importance of spending some time in teaching a proper plaque control to the patient. So only professional mechanical plaque removal is not effective if it's without oral hygiene instructions. In fact, only oral hygiene instructions may be more important than what you are doing in your clinics. So another study which actually compared the powered versus manual toothbrushes for safety and efficacy, it was seen that the change over the difference with the two was not much for normal subjects. For example, if the patient doesn't have much dexterity, those patients may benefit more from the powered toothbrushes rather than the manual toothbrushing. So if we take this mechanical plaque control with the normal brushes, with the mechanical removal, or with the powered brushes, we can make 2 or 3 take home points. That plaque can reduce the incidence of biofilament gingivitis with the repeated instructions, that is very important, and encouragement much more effectively than with self-acquired oral hygiene habits what the patient has learned. So you have to modify bit by bit about how the patient is performing his oral hygiene, and be sure to inform the patients that home care procedures on full dentition takes 5 to 10 minutes, and for complex periodontal cases it may take almost 30 minutes. That's what I was telling you. If we are brushing 2-3 times and we are taking normal dentition 2 minutes, that if a patient is having periodontal disease plus he's having a processes in the oral cavity, some cavities filled and all, it will take around 30 minutes per day for his plaque control. And failing to provide positive reinforcement, we are again saying about this positive reinforcement because it's very important that every time patient comes to you, you should be given, and not only rely on what you are talking to him, provide him some written material, some pamphlets and some printed materials, so that that can be reinforced better way. So there are now there are some things that we over a period of time we have seen that public compliance and professional healthcare intervention may not be so effective, because we still see that there are lots of patients who are having gingivitis and periodontitis. So the research was taken in this direction that we could use some materials which could control oral biofilm formation um, without any much dexterity on the patient's part. So what was done in 2010, there's a study in JDR which said that the use of nanoparticles can be effective in the control of the biofilm. So nanoparticles in the size of 100 nanometers, they have biocidal and anti-adhesive property. Anti-adhesive that they will not lead to the formation or adherence of the plaque onto the surfaces, and they are biocidal, so they will kill the bacteria. So these nanoparticles basically consist of very small particles of silver, copper, zinc, silicon, and other oxides. And and they what they lead to, they lead to the pore formation in the bacteria and kill the bacteria. So this development of these particles was done to be incorporated in the mouthwashes, dental paste, and other oral hygiene materials. And they could be an alternative for the oral hygiene methods that is done with the mechanical toothbrushing only. Another advancement in the oral this prophylaxis or oral biofilm control is the development of lasers. So if we are using lasers in the interdental area, that laser, a low level laser, has been shown to kill the microbiota in the pocket. So this is one another method of biofilm control. Another method that has been advanced is that the photodynamic therapy. Photodynamic therapy is the involvement of light and oxygen in a photodynamic process, which was started by von Tepinier, who coined the word photodynamic. It has been seen that what I was telling you, that antimicrobials could develop resistance. So it was developed as an alternative to the chemical antimicrobial agents, so that we could treat the periodontitis or control the plaque. So basically the light activates some photosensitizer which goes to the excited level, and it releases singlet oxygen, and those singlet oxygen will ultimately lead to the bacterial destruction. So this is a method of killing the bacteria without using the antibacterials. So there are many types of reactions that occur. The single particle of photodynamic molecule can be excited, and it can remain in the excited portion and ultimately lead to the formation of oxidation products, and ultimately lead to the pore formation in the bacteria and the killing of the bacteria. So many commercial types have been developed where the laser tip was developed and it was used with some photo sensitizer, and that was used for the treatment of the or the removal of the biofilm or the killing of the bacteria in this. And another, there is now not approaching like killing the bacteria. We could have another method of substituting the harmful bacteria with the beneficial bacteria. So from there, the concept of probiotics has been developed, and it was proposed in 1965, and as an antonym to antibiotic, because we don't want to use antibiotics. Probiotics are the live microorganisms which, when administered in adequate amount, confer a health benefit to the host. So we are actually replacing the unfriendly bacteria with the friendly bacteria like lactobacillus. And probiotics, they have an antagonism against the pathogen, and they resist bacteria, they cause the inhibition of the pathogen overgrowth, and they cause immunomodulation, which all leads to the development of health in the oral cavity, because now there is no site for the pathogenic bacteria to adhere to the tooth surface and cause disease. So what are the different types? That oral lactobacillus strains, they exert an antimicrobial activity against periodontopathic bacteria, for example AA and Porphyromonas gingivalis and Prevotella intermedia. So this could be substituted for the pathogenic organisms. So these are the different types of effects of the probiotics. And the evidence is that probiotics can actually not only kill the bacteria or replace the pathogenic bacteria with the beneficial bacteria, they can also reduce the level of the cytokines or inflammatory mediators in the pockets. The levels of TNF alpha and IL-8 also decreased in the probiotic group. However, these effects were temporary and the levels returned to baseline after probiotics had been withdrawn. It's only because these probiotics have a very limited time of action that they did not actually receive a lot of attention, and not a lot of research has been going on this, because they need to be used very frequently, which may not be possible. And again, the issues of the compliance from the patient's point of view may come. So another concept which has been developed in 1990 is the full mouth disinfection. What we are trying to do, that we are removing plaque on a professional basis within 24 hours. What we are trying to do is that we are not allowing the bacteria from one side to repopulate another size. For example, if you are doing per quadrant scaling and you are removing the plaque from that, by the time the next appointment of the patient comes, the plaque, the bacteria from the untreated site may actually repopulate that site and again cause disease. And by the time, because you are doing now the scaling in only other region, this area, the region which was earlier treated, may develop periodontitis or gingivitis over a period of time. So full mouth disinfection gave the concept that we are trying to treat within 24 hours both the types and not giving bacteria enough time to repopulate, colonize, or divide or grow over a period of time. Another method that was used, that is an advancement in the plaque biofilm control, is the use of subgingival air polishing. What we are doing is that we are actually directing a slurry of aluminum oxide into the pocket and trying to remove that. So there is a basic pressurized air chamber where from the and water comes and air and powder particles are delivered in the bacteria in the pocket, and they will try to kill the bacteria in that area and disrupt the plaque. So this is about there. There are the larger particles which will disrupt deeper in that area, and there are the smaller particles which will depress less. So the summary is that the calculus removal and not root smoothness has been shown to be necessary for tissue health. It might be more prudent in such a case to stop short to perfect smoothness and reevaluate the patient, because we know that plaque does not penetrate, it just adheres, and this will avoid over instrumentation. Another method is the subgingival irrigation. So it was first introduced by Newman in 1982, and it's an intentional direction of fluid in the pocket or in the crevice, and it's directed towards the gingival margin. So there, the rationale is that we reduce the pocket microflora to prevent initiation of periodontal disease or to facilitate their reduction. If we are directing the nozzle towards the pocket, we see that there is reduction of around it penetrates around 75 to 93% of the pocket depth, and the organisms that are left behind, that are removed by the subgingival irrigation. So subgingival irrigation is further divided into home irrigation and professional irrigation. It's always the subgingival irrigation. And this, we also conducted a study in Yamunanagar where subjects for the study were taken from our OPD, and complete dental and medical history was taken. 40 subjects with the pockets greater than 5 millimeter were recruited and randomly divided into group A and B. And in group A, patients were given undergoing scaling and root planing and given twice daily rinsing with 0.12% chlorhexidine mouthwash. In the group 2, patients were underwent scaling root planing and they were given water flosser and sonic toothbrushing twice morning and daily. And we saw over a period of time the evaluation was done as 2 week, and GCF collection was done to evaluate the pro-inflammatory mediators at 4 week and at 12 weeks. So the results are that there was a reduction in the probing depth, there was gain in the clinical attachment level, and we took the bleeding on probing index and stain index, and what we concluded is that home irrigation is safe and effective for a wide variety of patients, including those in the periodontal maintenance, maxillary fixation, crown and bridge, implants, and diabetes, and those who are not compliant with the floss. So clinical outcomes include the reduction of the plaque, calculus, gingivitis, bleeding on probing. So this was all the results of our study that was carried in our department. So I want to conclude by saying that while technological advances have introduced a range of different instruments and novel techniques over the past decades, the critical factor for successful non-surgical periodontal therapy or the plaque control remains the thoroughness of root debridement and the patient's standard of oral hygiene rather than the treatment modality. Thank you so much, and I would again wish you a very happy oral hygiene day, and I wish that people there is more awareness in the public, and we are the ones who can develop this awareness and actually try to inculcate good oral hygiene methods to the patients. Thank you so much.